Staff are in listen-only mode.
Good evening and welcome to tonight's webinar on how to do ultrasound of the lung, presented by Drs. Michael Blaivas and Anjali Bhagra. During tonight's presentation, participants will learn the basics of using ultrasound for evaluation of the lung and become familiar with ultrasound use at the bedside and in the office. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this educational activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. During tonight's presentation, if you have questions for the presenters, you may submit them by typing them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenters will not begin answering until the end of the presentation, at which time they will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now to begin, we're pleased to present Dr. Michael Blaivas.
Good evening and welcome to this webinar on lung ultrasound. What is it and how do I use it on my patient? Thank you for being with us tonight. My name is Mike Blaivas and I also have the great honor and pleasure of doing this webinar with Dr. Anjali Bhagra, who is a true innovator and pioneer in the area of point-of-care ultrasound in internal medicine. So ultrasound is a very big topic now. And I do have one disclosure that's related to it, and that is I've done some consulting with GE. It's a product that will not be mentioned at any time during my portion of the webinar. We have several objectives, and they include gaining understanding of basic ultrasound artifacts and principles, to recognize the limitations of lung ultrasound, as well as being able to describe common lung ultrasound pathology signs. And finally, to understand the use of ultrasound adjuncts in lung evaluation. So how does ultrasound of the lung really work? It's commonly taught, or has been in the past, and has been written in one of the greatest textbooks in the House of Medicine, that lung is a major hindrance to the use of ultrasound at the thoracic level. A similar statement in Harrison's postulated that ultrasound imaging is not useful for evaluation of the lung parenchyma. And that was actually the case until 2012. If ultrasound does not penetrate air, how can we image the lungs? In fact, in normal lungs, we can only image the pleura, and the detail we get is fairly limited. So if you look at the chest wall here and the lungs expanding, we really only get to about this point and not any deeper, unless there's pathology. So why would that be helpful at all in imaging lung pathology? Well, one of the most important things is that we can actually see that there's evidence of the lung expanding and then contracting. And this produces a to and fro motion between the parietal and visceral pleura. And this is something that's very critical, and we'll talk about throughout this presentation. The pleural line, in a way, is the basis of lung ultrasound. As ultrasound passes through skin, soft tissue, between ribs, it finally hits the pleura, and we can track all of that. It probably doesn't get very much deeper, at least medical ultrasound doesn't, in the healthy lung. In this case, we have our ultrasound transducer starting on the patient's chest, and this is the image that we see on the left. As the ultrasound beam enters the patient, it hits the skin, chest wall, goes into the thoracic cavity and onwards, although we can't really get much feedback beyond the pleural line. On the left image, the same process happens. Ultrasound beam comes down, goes through the skin and deeper. The part that we can really see and get any information about starts right here at the skin level, and for all intents and purposes usually ends at the pleural line level. Below that, the lung is just too well aerated and we don't get much information. And here's the comparison on the left. This is actually ultrasound gel. This is the skin, subcutaneous tissue. We start having some fat here, muscle. This is mostly muscle. And here we have ribs. This is a sagittal orientation. So we have an inferior rib and a superior rib. And just below it, we see the pleural line. Above it, some musculature. And this line is going to be repeated in many cases. In fact, we are starting to see a repeat right here. We don't actually see any useful clinical information below it. And that's commonplace. So how does this actually look? So here is a linear transducer on the chest, and we can actually see the ultrasound image being made as the ultrasound transducer runs from the superior portion of the chest to the inferior, and we can track the sliding lung or the pleural line throughout the video clip. We have ribs here on either side, and as we continue the ultrasound video, we can actually see that we've encountered something different. The pleural line is interrupted here, and this is a very important concept we'll talk about later as well. Now, what is causing that interruption? It turns out that this is the liver coming in and diaphragm. So below it, liver, diaphragm, and that's very important to watch. That can fool people. What happened here? Well, we lost contact with the body, or more than likely ran out of ultrasound gel. So that's an important factor. You can see the pleural line and actually appears to be moving back and forth. And interestingly, we actually image right through the rib in this case. That can happen despite all of the talks that people have heard about ultrasound not penetrating bone very well. In some cases it can, either in elderly demineralized bones or in the young. Again, we can follow this pleural line all the way around and notice that it's moving. Now, what happens at the pleural line? One answer is just about everything, almost everything we're interested in, because we don't see any farther unless there's some pathology like pneumonia. And the key for us is this sliding lung sign, and that's the most commonly accepted terminology. And this is the pleural line. We're seeing the visceral and parietal pleura moving against each other as the lung ventilates or expands, but typically we cannot make out individual pleural layers unless there's some significant pathology involved. And there must be actual movement, as we're seeing here, not just shimmering. And this can be a potential pitfall. So how do we get to make sure that there's a lung slide? In this case, the first glance may make you believe that there is a sliding lung sign, a positive one, that they're sliding back and forth, but there actually isn't. As we watch this, there's just kind of movement back and forth. It's actually a pulsation. Remember, sliding should be timed with the respiratory rate because it effectively reflects the lung being ventilated, expanding and contracting. This pulse is timed with this subject's heart rate. So it's a nice normal heart rate. They're not tachycardic, but we could actually put fingers on their radial artery and time the pulsation. However, there's some important things we can gather from this. This lung is not being ventilated, so it's not expanding and contracting, but it also means there is no pneumothorax at this rib interspace, and we'll talk about that a little bit more, and Dr. Bhagra will detail it quite a bit more as well. There are different ultrasound transducers we can use. Phased array is commonly used, but the pleural line isn't seen quite as well. Our depth is 15 centimeters. If we change it to 10, line a little bit better. I often have trouble making this out without glasses on even then. You can change the depth even further. And now we can actually start to see sliding. But these type of transducers are good at penetrating farther, and they have other uses that are excellent in lung ultrasound. We can also utilize the common curved abdominal transducer. In fact, it gives us several rib interspaces, perhaps even more than a linear. The view is better. We can see that pleural line a little bit more clearly as we decrease the overall depth. We could decrease it again and really magnify the image. We can track that pleural line. Here's the rib, and even see the soft tissue. Not quite as clearly as with a linear transducer, but still very nice. And this gives you a sense for the different range of transducers that could be utilized. Now, again, as we've mentioned before, ultrasound does not penetrate air effectively. As we see movement back and forth represented by the sliding lung sign and depicted here, we cannot tell that they're sliding if there is air between the pleural layers, because ultrasound doesn't penetrate through the air effectively. That way we only see the outside layer and not both the visceral and parietal, so there's no movement back and forth. Therefore, if you have a sliding lung sign, there cannot be a pneumothorax here in general. Now, sometimes it's hard to tell this, and it may be very helpful to use adjuncts, especially in the case of that phased array I showed earlier, where I had a tough time seeing where the pleural line was at the very top. Well, something that's an old and tried method is the M-mode cursor, or motion mode, and you can drop it down like this, let it run, and it will record motion along this path. Let's see what happens when we do that. A very nice display here. All of this soft tissue is going to be still, obviously, except for some minor breathing movement, and we have a smooth, continuous display. And then the pleural line, which corresponds to this bright line here. And below it, there's movement back and forth, back and forth. Now, this is just a continuous artifact of the pleural line. We're not really seeing any deeper. And what's interesting is when there's no movement of that pleural line, you have an appearance that's similar to the top. And it's important to be wary when you see an appearance like this that goes beyond or below the pleural line consistently across the screen. And Dr. Bhagra will talk about that more. There's another adjunct we can use, and that's color or power Doppler. The computer thinks that it is seeing blood flowing back and forth here, or even just in one direction, and it tends to display it. Power Doppler on many machines is a better option, and you can see here, this is called the power slide sign. It's great for documenting with a single still image, and also can sometimes enhance your ability to discern that there is actual movement there. Occasionally, you don't see lung sliding. Sometimes you see both. And here's a great example of that. We see nice lung sliding or pleural line sliding right up until here. For some reason, it seems to fade. Let's see what happens as we watch some more. The lung is coming in and out, or the sliding is coming in and out. In fact, this is known as the lung point. It's nearly pathognomonic for a pneumothorax, but as we saw very early, occasionally you can be fooled by other processes such as the diaphragm coming in and out. Be careful. One of the most important artifacts is the lung ultrasound artifact known as the B line. And in fact, here are B lines right there. They are defined as discrete laser-like vertical hyperechoic reverberation artifacts that arise from the pleural line, extend to the bottom of the screen without fading, and move synchronously with lung sliding. They're also commonly known as lung tails. The exact anatomic origin of B lines is still being debated, but they are a critical finding in the case of lung ultrasound, and Dr. Bhagra will tell you more about their clinical use. But this is a field view with one rib interspace with multiple B lines. Notice how it's easier to track B lines in video format with a live image rather than with a still image. It's hard to capture all the B lines that may be seen. Here's another case, multiple B lines using a curved abdominal transducer. And here is a blended transducer. It's a microconvex transducer. It gives us the best of both worlds potentially, although phased array, which gets in between ribs well, and a curved abdominal by giving us a broader image and a little higher resolution image. In both cases, we're seeing multiple B lines, and another term that may be used here by some providers is a B profile, meaning multiple abnormal B lines. Now, there's another important lung ultrasound artifact, and it's often termed the A line. It's linear and horizontal, and it is a repetition of the pleural line. Here's the pleural line. It would be sliding in a real-time image, but it's repeated several times. Some providers feel that this means that the lung is dry. We can see it in pneumothorax and COPD, also asthma, but basically we would not expect to see it in a wet lung. And in fact, the term A-line is somewhat downplayed by the international consensus that defined the B-line, and that's a very good publication to read. But interestingly enough, and this is well detailed in the consensus conference, you can actually see B lines even with A lines, and we're seeing them throughout. Not a high number perhaps, but we can definitely see them. Still, with the presence of A lines clearly seen on the screen as well. So something important to be aware of. Where can we scan? Well, there are a multitude of different protocols described. Some of the most common ones involve scanning approximately 4 regions per hemithorax. You obviously can scan the back as well. You can do this with the patient laying. And an important point is to scan above the diaphragm, since you may be used to doing this from different ultrasound studies, such as hypotensive protocol evaluations or even perhaps extended fast type examinations. When we look above the diaphragm, we can see fluid, we can see B lines, sometimes we can even see the lung itself. In this case, we see something that's very dark. And from our basic ultrasound physics, we know that anechoic regions like this should mean fluid, even though we can't tell what type of fluid. And we do see something familiar in this image, which is the liver and diaphragm, and above it, dark space. So that means fluid. And that's very important to note. How could we possibly see? Well, here's an example. It looks like we're seeing liver, fluid, and then a double liver. Well, this is actually lung. It is a consolidated lung, and another term for this is hepatization of the lung. And Dr. Bhagra will talk to us more about that in just a few minutes. Now it's time for me to pass on the baton. In summary, you can use different transducers for lung ultrasound. The anatomy is actually quite simple, as well as the artifacts, but you have to keep them straight. And now for the real fun of the practical clinical applications with Dr. Anjali Bhagra.
Hi, good evening, and welcome to the lung ultrasound webinar. Thank you, Dr. Blaivas, for an amazing introduction to lung ultrasound. I would like to acknowledge my colleague, Dr. Tierney, who's helped me with the slides for this session. So you are all experts by now in lung anatomy on ultrasound after Dr. Blaivas' introduction. In the next section, we are going to focus on pulmonary conditions and discuss various sonographic appearances and artifacts to help reach a diagnosis at the bedside. So to quickly revise for what we see in lung ultrasound, a typical view is the rib above, the rib below, and the visceral parietal pleura interface. And we see 2 different kinds of artifacts that are predominant in lung ultrasound depending on the amount of air and water distribution in the lung. On the left side, what you see is A lines, and these stand for air. On the right side, what you see is these vertical lines going from the pleural surface down to the bottom of the screen, also called as B lines. Let's look at conditions in which one would expect to see A or B lines and use the presence of these to derive a differential diagnosis at the bedside. I will divide the presentation into the following conditions. We will start out with pneumothorax and cover interstitial syndromes such as CHF, pleural effusions, as well as alveolar syndromes such as pneumonia and atelectasis. Let's start out with a case that we all see often in our practices, in the inpatient setting, in the outpatient setting, in the emergency department. A 35-year-old male patient who's otherwise healthy comes to your office for evaluation of chest discomfort after blunt injury to chest in a motor vehicle accident, which was 2 days ago. You obtain a lung ultrasound in the office and are struck by the finding of an absent lung sliding. So if you recall, in a normal lung, the visceral parietal pleural interface is seen as a shimmering or a sliding structure, also known as lung sliding or a pleural slide. So once again, in this image, which is a longitudinal image, here is the rib above, the rib below, and we are struck by the absence of lung sliding. What does this tell us? One can expect to see absence of lung sliding in various conditions of the lung, such as pneumothorax, but it's not exclusive to pneumothorax. You may also appreciate absence of lung sliding in other conditions, such as tethered lung, which may be secondary to a pneumonia, or an underlying ARDS, a big bulla, chest tube insertion, or a main stem intubation. How can one confirm or exclude a diagnosis of pneumothorax then with the help of ultrasound? Let's take a look at that. So here's a pictorial image just to remind us what happens in pneumothorax. So as we all know, there is replacement of the normal visceral parietal interface with air, which separates the visceral from the parietal pleura, which is what actually causes the absence of appreciation of lung sliding on ultrasound. How is this test done? Quickly going through the technique for a pneumothorax exam, one would like to obtain what's called a parasagittal view in a midclavicular line from top to bottom, with the patient being in a supine or semi-upright position, with the patient taking a couple of breaths at each interspace. So you want to scan all along that length, and normally what one would expect to see is the rib above, the rib below, and the presence of a beautiful pleural or lung sliding. Now this is absent in pneumothorax. Are there other functions on ultrasound that we could use to augment our exam? Because sometimes the human eye can get fooled by the presence or the absence of pleural sliding or the lung sliding. And you can actually use your machine to confirm that by using what's called an M mode, which is also called as the motion mode. And what happens in this is you throw a motion mode cursor across the normal image, and the M mode picks up movement across the visceral parietal pleural interface and causes this distraction, which is also known as the seashore sign. Okay, so here's a static chest wall, which is seen as horizontal lines. Here's the pleural surface, and beyond this, what you appreciate is a sandy beach appearance. In somebody with pneumothorax on the right side here, you can imagine the M mode cursor going through this area. There is no sliding appreciated at the pleural interface, and what you see instead is what's called a barcode sign. So here is the static horizontal lines of the chest wall. There is no movement appreciated at the visceral parietal pleural interface, and what you essentially see is a mirror image of this here, or also known as a barcode sign. What about the other artifacts in patients with pneumothorax? What does one expect with the A lines or the B lines? So here is pneumothorax, and there's air in the pleural cavity. One expects to see in those patients is presence of A lines, because remember, A lines are caused by reverberation of air. However, in a patient with pneumothorax, you would not expect to see B lines. Here is a useful algorithm to diagnose pneumothorax or rule in pneumothorax at the bedside. So the first question you want to ask is whether or not lung sliding is present. If lung sliding is present, you have ruled out pneumothorax. This is pretty sensitive. However, if it's absent, the next step is to look for the A or the B lines. So if B lines are present, once again, pneumothorax is not present. However, if you see A lines, you move on to the next step, which is to look out for what's called the lung point. The lung point is a transition point between the normal lung and the pneumothorax lung. So once you can confirm a transition point, you have very confidently ruled in pneumothorax with a specificity of 100%. However, if it's absent, there is no definite conclusion in that case. Is there evidence that ultrasound helps much more than other imaging modalities for pneumothorax? Sure enough, it does much better both with sensitivity and specificity as compared to our normal portable chest X-ray, which is what we all order in our offices. So let's move on to another common scenario that we come across in our outpatient or inpatient practices. Here's a 55-year-old man with a 60-pack-year history of smoking with known COPD, a prior coronary artery bypass graft, and a reduced baseline EF at 35%. And he presents to your office with worsening cough and shortness of breath. Now, we all know that CHF and COPD both are huge healthcare burdens in terms of cost of healthcare, but also in terms of, at a provider level, sometimes not having clarity of diagnosis. Oftentimes, what we end up doing for these patients, as we all know, is a cocktail of albuterol, antibiotics, as well as Lasix, because we try to cover all ground. Now remember that lung is at a cornerstone and intersection of ventilation and circulation, and it can give us a lot of helpful information. The downside, though, is that physical exam, traditional physical exam, is not very helpful when we are trying to make these diagnoses. So how can ultrasound help us in ruling in interstitial syndrome such as CHF and differentiating it from other potential conditions that can cause similar presentations such as COPD? And in these cases, what we want to capitalize on is trying to look for the predominant pattern in the lung. As you can see here in the image, one can appreciate several broad B lines in the video. And while B lines form the cornerstone of interstitial syndrome diagnosis, it's really important for us to train our eyes to what they look like. So what we are looking for is these helicopter searchlights in the lung, also known as comet tails, as you've already heard from Dr. Blaivas. And it's interesting that although semantically unrelated, B lines actually correlate with curly B lines that we are taught traditionally to look out for in patients with CHF on chest X-ray. And these are not easy to see on chest X-ray, but trust me, B lines can be easily seen with the help of handheld ultrasound on the bedside. And it's also true that the number of B lines that we see on the screen or the distance between the B lines can allow us to actually assess severity and also monitor our patients real time for response to treatment. So let's take a look at how interstitial edema first appears in the subpleural septa, which is what makes these B lines. So as you can see, different examples starting out to the left side of the screen. You can see B lines being formed by the pleural line fluid air system interface reflecting sound waves again and again, which get trapped and create this B line RFI. And you can see them as, broad 7 millimeter lines, which would indicate a coarse interstitial edema, versus in this case, as we move to the right, you can appreciate these are very thin, 3 millimeter, fine, yet confluent lines, which may indicate the extension of this interstitial edema into the alveolar space and leading to more of an alveolar syndrome. Let's move on to how to use ultrasound for pleural effusion. Ultrasound is very, very helpful and handy to diagnose pleural effusion. It is much more superior to chest x-ray. On chest x-ray, often a white opacity could mean a fluid, an atelectasis, or a consolidation, but with ultrasound, you can clearly visualize what's going on in the lung. So here's a quick refresher of the technique that one would use. And to look for pleural effusion, we want to scan in a coronal view and obtain a coronal view with the indicator towards the patient's head. And here is what our scanning plane looks like. And what we are trying to look for here is an anechoic or a hypoechoic area which corresponds to pleural effusion. So as you can see in this longitudinal image, once again, here is the head of the patient. This is the foot side. Here's the diaphragm with the liver below. And what you can appreciate here is a big collection in the pleural space, which is represented by this anechoic area. What you can also appreciate here is the tongue-like white projection of the atelectatic lung into this pleural space. Okay. Let's take a look at what happens in a healthy person. So as you can see this image on the left, it's a longitudinal image once again. Here's the head side of the patient. Here's the foot side. You can appreciate the diaphragm, this bright white curved line, the liver, the kidney. And what you can appreciate beautifully here is the lung wrapping over almost like a curtain over the liver. This is called the lung curtain. You can also appreciate a mirror image of this liver on this side and this area right above the diaphragm. This is what one would expect to see normally. In somebody with pleural effusion, however, see how this looks different. So what you can appreciate here is the diaphragm, the liver, but there is no mirror image of the liver above the diaphragm, but you can appreciate this black anechoic area which represents pleural fluid. Are there other indirect signs that one can use to diagnose pleural fluid on ultrasound? The answer is yes. What we could look for is something called the spine sign. What do I mean by that? So in a healthy patient, what happens is that the extension of the thoracic spine superior to the diaphragm should not be seen because of the high acoustic impedance of the lung that is sitting right above the diaphragm. However, when pleural fluid replaces this, and in case there's a consolidated lung, there's even a better acoustic window, and one can actually appreciate the thoracic spine extending over the diaphragm. This is also called the spine sign, and you can see several examples of how the thoracic spine extends over the diaphragm. Now, let's look at this image here on the right side, the bottom right. It's not very clear if this is a mirror image or if this is pleural fluid, but the presence of the spine sign tells me that there is a collection here. It is not very anechoic. It's a complex fluid, perhaps, as compared to this collection over here. So try to look for or when you see the spine sign, one must suspect presence of pleural fluid. Okay, so are all pleural effusions simple and anechoic looking? And the answer is no. You know that the pleural space can have accumulation of blood, of pus. So depending on what's accumulating in the pleural space, the appearance can vary. You can see examples of loculated pleural effusion on the top left column there, as well as the bottom left. And on the right, what is seen is an example of an empyema on ultrasound. Let's move on to our last category today, which is that of alveolar syndromes. And how many times, we come across findings of atelectasis versus consolidation in the lower lung field. Is there a way we could use ultrasound to further study these and pick most suitable treatment for our patients? Let's see how consolidation looks on ultrasound. So remember I told you that in a normal person, one would expect to see a mirror image of the liver above the diaphragm in the absence of any pleural fluid or consolidation in the lung. Now, lung ultrasound is all about a balance of fluid and air and how we can pick that up with sonography. As you can see in this case, once again, this is a longitudinal image. Right? Here's the head end of the patient. Here is the caudal end. What we appreciate beautifully is this diaphragm that separates the liver from the thoracic cavity. But let's look at what's happening above the diaphragm here. Now, this lung does not look like normal lung, right? What we can appreciate here is that the lung actually looks somewhat a little bit like the liver. And what I can also appreciate here is a little bit of pleural effusion. So what we are seeing in this video here is a consolidated lung with air bronchogram and a thin pneumonic effusion, which corresponds to this CAT scan appearance that you see here. Now, in contrast, if you look at this image here, one can appreciate the diaphragm, the liver, the pleural effusion, this anechoic space right above the diaphragm, and this tongue-like protrusion of the lung, which is flopping around in the pleural fluid. And this represents an atelectasis lung in comparison to this video that shows a consolidated lung. Here are some other examples of consolidation and pneumonia. Once again, in the center video here, you can appreciate the diaphragm, the liver, you can appreciate the pleural fluid. What I can see beautifully is that the lung looks more like the liver. In other words, it's hepatized, it's consolidated, and you can also appreciate these air channels, these white streaks that are going, in the lung. There are all kinds of names given to these. You're going to hear the shred sign, which is all these shreds of white strands in the lung. But this is really representing air within the consolidated lung. Here are some other examples of consolidation on static images. Let's move on to understanding the air bronchogram a little bit better, because this can come in very handy at the bedside to make a quick diagnosis. Now, your best bet of picking this on ultrasound is if this is subpleural or more peripherally situated. In instances of posterior consolidations, or if it's very deep in the lung tissue, you may miss it on ultrasound because you may just see an overlying A pattern due to the normal lung. Okay, but here's what classic air bronchogram looks like on ultrasound. What I want you to appreciate in all of these images is the movement of these white streaks over time. And what I'm depicting here is called a dynamic air bronchogram. So with inspiration, this air comes in and goes out with expiration. So the bronchial tree is getting outlined dynamically by air with the use of ultrasound in this consolidated section of the lung. Here is another example. You can beautifully see the bronchial tree with inspiration. There's bright white air coming in, expiration goes out, comes in again with inspiration. And this is not just fun to watch. My patients get much more engaged when I share these pictures with them. They're more compliant with their antibiotics. They are more willing to do everything else in terms of conservative management to make their lungs healthier. So that's air bronchogram in a dynamic mode, which can quickly help rule in a diagnosis of pneumonia at the bedside. Here is an example, as I showed earlier too, of an atelectasis lung. This is one of our patients who's had shortness of breath and discomfort post-operative for a long time and has collections bilaterally in the lung. And we chose to not treat this patient with antibiotics as he's had these findings of post-compressive atelectasis in his lung tissue, and this does not represent a consolidation. In a chest x-ray, you would just see this as a white opacity, and it would be very difficult to triage, as I said earlier, the most suitable management. Versus this patient was treated with antibiotics for presence of a consolidation in the lower lung field. All right, to summarize, here is a normal lung showing findings of a normal lung sliding with A lines. Here's an example of a pneumothorax with absent lung sliding and presence of A lines. Here's an example of a patient with CHF with interstitial edema and plenty of C lines or lung rockets. Here's an example of pleural effusion with this hypoechoic and echoic area above the diaphragm that we landed up tapping. Here's an example of consolidation in the lower lung field, which we landed treating with levaquin. And here's an example of our patient with atelectasis and pleural effusion. Remember that ultrasound is not only used to just augment your physical exam at the bedside, to give you the most tentative diagnosis, to pursue the most suitable treatment, but you also have to trust your findings because it helps monitoring treatment. I would like to quickly put a plug-in for the Blue protocol that has been discussed by Dr. Blaivas. You can use the A profile, the B profile, or the AB profile and help guide your management at the bedside. We've discussed at length at how these appearances are in various conditions. So I would like to end by inviting you all on this fabulous, adventurous journey of lung ultrasound. Have fun, get trained, and use and trust your findings to make best decisions for your patients.
Okay. This is Mike Blaivas. I want to thank all of you for attending the webinar. Fortunately, we have about 15 minutes left in which to take some questions, and we already have several stacked up. What I'll do is read the questions out loud. I will anonymize them, and then Dr. Bhagra and I will answer them. Some of the first questions are actually excellent ones, but probably beyond the scope of this presentation, but we'll tackle them anyway. One of the audience members asks, can you detect pleural plaques of the asbestosis and mesothelioma? And I'll go ahead and take the first stab at that just based on the literature that's out there, and then Dr. Bhagra can add some relevance from office and in hospital perspective. So it actually turns out that you can detect evidence of asbestosis and mesothelioma because many times there are significant pleural changes. And as was mentioned several times, the pleura can be visualized very well, especially with a high-resolution linear transducers. You can actually see focal pleural thickening in mesothelioma, although you can see it with fibrotic processes as well. But once mesothelioma becomes more advanced and progressive, it does take on a characteristic appearance. There's no good evidence-based data out there supporting our ability to differentiate it, but There are some great articles on this topic. One of the foremost authorities in the world is from Europe, Germany, I believe, Dr. Mathis. He is very adept with pleural ultrasound. And in 2012, there was a nice article that came out of the University of Indonesia by Dr. Rumende, and I'm probably completely distorting that last name. And that depicted lung ultrasound use in pleural diseases and specifically mentioned asbestosis, mesothelioma, and pleural-based tumors. I think at this point, Dr. Bhagra, if you have anything to add, I know it's a little bit of a out there topic, but if you could chime in.
Well, I would fully agree with what you said, Mike, to begin with. And I think, practically speaking, at the bedside, the examples that both Mike and I showed you today, if you just can recollect, all of these had a very uniform appearing pleural lining. And I think when you're struck by the absence of the smoothness of a pleural lining, or in other words, if you find that the pleural lining is sliding, but it looks, let's say, lumpy and bumpy, or if it looks rather irregular, or you begin to notice nodularity. I mean, those are all clues to something going on, which, you know, something that would point perhaps towards a pleural process. So I'm not really specifically talking about a mesothelioma only, and I would encourage you to look up the resources that Mike just mentioned, but at the bedside, when you're doing binary decision making, just the appearance of the pleura itself, whether it's smooth or not, can give you a lot of information.
Thank you, Dr. Bhagra. A related question from the same audience member is written as, can you differentiate fibrous tumor, benign versus malignant mesothelioma? And it turns out that fibrosis will often have a fairly classic appearance, multiple B-lines, thickened pleural line. There are variations on this as well. A malignant mesothelioma will typically have a focal mass or tumor that you can see at the pleural line, and the resources I mentioned earlier are both excellent in terms of getting to attain a more in-depth understanding of pleural ultrasound, and there is a term that refers specifically to that other than lung ultrasound. And several researchers around the world have been doing research on this topic for over a decade, and really have developed their own subfield to some degree. I'm going to jump to the next question, and I'll answer it and give one point of view, research, and then I'll ask Dr. Bhagra to give the clinical and reality anchor to this. And the question is, can you differentiate benign versus malignant effusion? It does turn out that there are some findings that will help you differentiate. For instance, freely floating echogenic particles that swirl in the pleural effusion are thought to be associated with malignancies, and sometimes finding actual masses within the pleural effusions themselves. But in terms of a clinically realistic approach, I'll ask Dr. Bhagra to chime in and give us the true perspective on this.
Thank you, Dr. Blaivas. That's an excellent question. Thank you for bringing this forward. And I actually omitted this in my presentation. We have to remember what we are seeing on ultrasound is an imaging finding. And you have to put this in clinical context. So, for example, that image with the pleural effusion and the underlying atelectasis that I showed you earlier, a very similar appearance was seen in a 78-year-old gentleman with a central mediastinal malignancy with a post-obstructive atelectasis and an anechoic looking effusion. And so just merely by appearance, it is very difficult to 100% rule out or rule in malignancies. But what Dr. Blaivas just earlier alluded to, those are helpful pointers. So if you're seeing more of a complex effusion, or by the nature of the effusion, if it looks more like a pneumothorax and is recurrent, those are clues in addition to ultrasound that you want to use in a clinical context. But ultrasound does not replace a pathological diagnosis, and you have to put clinical context into consideration with these findings.
Thank you, Dr. Bhagra. Next question, also a very good one, and I think we'll both tackle it as well this time. And this question reads, in speaking of undifferentiated shortness of breath presenting, can you comment on the finding of A-line pattern in pulmonary embolism? And I'll touch on some of the literature out there, and Dr. Bhagra will tie this in again to practical clinical reality, although she knows the research better than I do. But it just gives me a chance to say something. So if you follow the blue protocol, the A pattern almost seems to steer you towards exclusion of other causes of shortness of breath. And Daniel Lichtenstein may correct me on this and refine the answer better, but some of the work on pulmonary embolism has also been done by Dr. Mathis. I believe I'm correct in saying that he is an internist from Germany, and as I mentioned before, has considerable expertise in pleural ultrasound. And in 2005, he published a study in chest looking at ultrasound and pulmonary embolism, and they found that they could confirm pulmonary emboli when they identified more than two or more standard triangular pleural-based defects that probably represented ischemic processes in the lungs, infarcted lung. If there was one such lesion and a pleural effusion, or a possible PE if there were some subpleural lesions in a single pleural effusion. So they actually did not discuss the A pattern, A lines very well. Their sensitivity and specificity were quite reasonable given that they were comparing to CT angiography. And I believe they recorded a sensitivity in the 74–75% range and a specificity of 95%. And one of the greatest things about lung ultrasound is it can help you move away from some of the things on your differential. And I think at this point I'll let Dr. Bhagra extrapolate on that and tie this all together.
Thank you, Dr. Blaivas, for sharing that study in 2005 that was published in Chest. And actually, if we go back to what they described in that was a typical Hampton's hump, which we were taught in medical school as a pleural-based wedge-shaped opacity to look for in chest x-ray and someone suspected to have PE. What I would like to add to what Dr. Blaivas has already discussed from a clinical standpoint is that one can always combine, remember you can always combine lung ultrasound with the lower extremity DVT study if the suspicion is high and if you're seeing a pattern and some of the other findings that Dr. Blaivas discussed. And if you come across lack of compressibility, and again, we are not going to cover this in detail, and there is data, highlighting sensitivity and specificity. But the point that I'm trying to make here is that you can expand your lung ultrasound to include some of these differentials.
Thank you, Dr. Bhagra. Now taking a turn into a slightly different direction, a more technical, and this I'll let Dr. Bhagra tackle first. And I might chime in as well afterwards, simply because this hints at the individual preference that providers can develop for using ultrasound. And the question reads as follows. do you prefer same system settings when looking for consolidations as you do when looking for artifacts at the pleural layer? And Anjali, if you want to tackle that first.
Yeah, and that's a great question. And this is almost like, you know, when I go rounding, we always joke about this. We all carry different brands of stethoscopes, and we all have different ways of approaching a physical exam. So from my experience, what I would chime in is for a pleural-based assessment, I always start out with a linear probe at high-frequency settings. For somebody who might suspect to have consolidation, or also depending on the availability of equipment, it's not a bad idea to start out with a phased array probe with some standard settings of starting scanning at a depth of around 8 centimeters. You know, and you could always start deeper and get more shallower if you find pathology more pleurally located or subpleurally situated. Remember what I highlighted when I was discussing the section on consolidation is that if you are trying to pick up a small area of consolidation that's rather posterior and deep to a surrounding normal lung tissue, there's a good chance you'll miss it anyway. I do tend to start deeper when I'm suspecting consolidation compared to when I'm doing a pleural assessment. I prefer to start out with more superficial settings and using a high frequency probe and moving on to a lower frequency probe for consolidation. Mike, what do you preference?
I am at a loss for what to add to that. The one thing I can suggest, and this may be specific to my eye only, is changing the preset you might be using. If you do not have a lung preset on your machine, especially for the linear, I find that using a vascular or venous type preset for the linear probe helps me bring out sliding lung more easily, as opposed to, let's say, a breast preset or some MSKs. But then the pleura may be better defined in an MSK preset. So if you have that option, that is something to consider, because the enhancements allowed by those different presets change the appearance that you see on the ultrasound screen. And sometimes it's a subtle change. Sometimes it's pretty significant, and you can really benefit from a different shading, different clarity, etc. I think we might have time for just one more question. And this is one I'll pass on to Dr. Bhagra as well, and chime in only if needed. This is an excellent question. Can we measure fluid to quantify it in pleural effusion for classification purposes as we can in the abdomen? And we'll just leave it at that.
So, and you know, this is beyond the scope of the seminar, but you can actually measure the pocket size, so you can measure the distance between the visceral and the parietal pleura, and based on the measurements you can guesstimate the size of the pleural effusion. I will though mention that a chest x-ray, for example, would pick an effusion that's 150 milliliters or bigger. But with ultrasound, you can actually pick up significantly smaller effusions. And hopefully in subsequent seminars on advanced applications of lung ultrasound, we'll be able to discuss some of those details. And I know one of my colleagues at Mayo has actually done a lot of work in this field, Dr. Sekiguchi, and it'll be fun to do the next series to discuss further nuances of how you can utilize different measurements and volumetric assessments.
Thank you, Dr. Bhagra. And there are some articles out there. Our listeners can look up on Medline or other resources that go over some of these quantification approaches. At this point, it appears we're nearly done at 8 o'clock, and we don't want to keep people up past our slotted 1 hour. I know on behalf of AIUM, ACP, Dr. Bhagra, and myself, and everyone involved who's helped to make this happen. I want to thank you all for tuning in or listening to this recorded webinar at a later point. And please enjoy lung ultrasound, and we hope that you recognize how useful it can be in your patients right at their bedside.
This has been a wonderful webinar. Thanks very much to both of our presenters, and our thanks to all of you who participated tonight. Everyone, please remember to complete the post-test and the activity evaluation. We hope you enjoyed this evening's presentation and will join us again for future webinars. Good night, everyone. Have a great evening.